Good afternoon, everyone. My name is Catherine Bennett. I'm the Head of Marketing and Communications at the EBOS Group for Institutional Healthcare. Welcome to HPS Pharmacies' first webcast lecture. Our clinical pharmacists have been delivering lectures in hospitals, clinics, rehabilitation centres and correctional facilities for over 10 years now. Currently, we recognise there are some limitations in this face-to-face format. Also, some nurses do find it difficult to attend an in-service occasionally. So we hope you find this new format to deliver a selection of lectures from our series will help more of you gain greater access to this important information. We are recording this lecture for on-demand playback. Notes will also be available by emailing us following the event. A prompt to do this will be sent to you within 24 hours of this event. Our agenda allows for a 5-minute Q&A at the end, so please type your questions into the Zoom interface at any time during the presentation so Nicole can respond. Also, at the end of the session, you will be prompted to respond to a very quick feedback survey. Now it gives me great pleasure to introduce Nicole Dilworth. Nicole is a clinical pharmacist who has worked at HPS Pharmacies, Hobart for almost 11 years. Nicole is passionate about hospital pharmacy, regularly contributing to the profession through initiatives such as the development of learning modules for the Australian College of Pharmacy and presenting at the Medication Management Conference for the Society of Hospital Pharmacists of Australia. Today, Nicole will be speaking on the topic of gestational diabetes. We hope that you enjoy this presentation and find it useful to your practice. I will now hand over to Nicole and thank you again for joining us.
Thanks so much for the introduction, Catherine. So today we'll be talking about gestational diabetes. So what is gestational diabetes? Gestational diabetes is glucose intolerance that's first detected during pregnancy. So if a woman has been diagnosed with diabetes prior to becoming pregnant, we wouldn't consider her to have gestational diabetes. We would consider that she has diabetes in pregnancy, and they are handled differently. The reported prevalence of gestational diabetes does vary due to factors such as ethnic background. For example, those of an Aboriginal or Asian background have a higher prevalence of gestational diabetes, and the diagnostic criteria used to make the diagnosis. Gestational diabetes between the years of 2014 and 2015 was found to affect up to 8.9% of women. So it is quite common. What causes gestational diabetes? So there are hormones that are released by the placenta during pregnancy, and these can affect the glucose tolerance of the mother. So those hormones include human placental lactogen, human placental growth hormone, progesterone, and estrogen. And during pregnancy, the pancreas needs to increase its insulin production, and that actually might need to go up to 3 times the amount of insulin that it would normally have to make to compensate for this glucose intolerance. And that's quite a lot for that to need to do. The insulin that the pancreas does produce isn't used as effectively by the mother, so that's why we start getting higher blood sugar levels. So screening for gestational diabetes, Australian guidelines recommend that this should commence somewhere around 24 to 28 weeks of gestation for all pregnant women. So all women should be screened for gestational diabetes, and some women who are at higher risk should actually be screened earlier in the pregnancy. And some women that are screened earlier in the pregnancy may also need to be screened again later in the pregnancy if that first screening didn't identify gestational diabetes. So what are the risk factors that can contribute to the development of gestational diabetes? This includes having gestational diabetes in a previous pregnancy, elevated blood sugar levels before becoming pregnant, a family history of diabetes, obesity, so a BMI of over 30, polycystic ovary syndrome, certain ethnicities that I've mentioned already, Maternal age, so with increasing age, particularly if the woman is over 40 years old. A history of macrosomia, so what that means is a high for gestational, high birth weight or high for the gestational age. And medicines that are associated with hypoglycemia, so for example, that would be things like corticosteroids or antipsychotics, can be a risk factor as well. So how do we diagnose gestational diabetes? What we would usually do is an oral glucose tolerance test. And what this involves is taking a fasting blood sugar level, a plasma glucose level first, and then administering a 75-gram dose of glucose to the mother. That would usually be consumed in the form of a drink, so a 75-gram drink of glucose. And then we measure the plasma glucose level at 1 hour and then again at 2 hours. Now, the 75-gram glucose drink isn't very pleasant. It's not a pleasant test to go through, and some women do find that it can make them feel nauseous, and some can also find that they do throw up. If that happens, then potentially they may need to have a repeat test done because it would be difficult to interpret those 1 hour and 2 hour plasma glucose levels if we're not 100% sure how much glucose was consumed. So the results of those blood sugar levels can help us to either diagnose gestational diabetes or diabetes in pregnancy, depending on what the level comes back as. So if the fasting level is below 5.1, so if, for example, the fasting level was 5, then the woman wouldn't be considered to have gestational diabetes. But if it was between 5.1 and 6.9, then that would be the diagnosis that was made. But if it was over 7, then that would actually indicate diabetes in pregnancy rather than gestational diabetes. So these levels too are more for the 2nd and 3rd trimester for the diagnosis of gestational diabetes. So what's the consequences of this diagnosis? The risk of adverse pregnancy outcomes increases with the increase in maternal blood sugar levels. So there was a 2008 study called the HPS study that actually found that as maternal blood sugar levels increase, so do the risk of adverse pregnancy outcomes. We can break those outcomes down into consequences for the mother and consequences for the baby. So consequences for the mother include hypertension and developing preeclampsia, potentially needing an induced labour, a caesarean section birth, experiencing birth trauma, needing an extended hospital stay, and also an increased risk of developing type 2 diabetes. And that risk is quite high. So I think within somewhere like 10 years, 50% of women that have been diagnosed with gestational diabetes will go on to develop type 2 diabetes. So it is significant, and this is therefore something that we would want to monitor the woman for after she's given birth, to make sure that this doesn't occur or that we are managing it if it does, because it is a high risk. Having said that, after the mother does give birth, usually gestational diabetes does resolve. So with most women, they will go back to having normal glucose tolerance after they've had their baby and the placenta that's producing those hormones has been removed. So the consequences for the baby can include a high birth weight, birth complications, so for example, shoulder dystocia, jaundice, being overweight during childhood, and they are also at an increased risk of developing type 2 diabetes. So these risks or the outcomes are quite significant. So how do we treat gestational diabetes? Initially, we'll try lifestyle changes, and lifestyle changes are actually enough to manage the blood sugar levels in over 50% of women. And the lifestyle changes that we make would include things like diet and exercise. The women would get some education from a diabetes educator and potentially some nutrition advice as well. When we talk about the diet that a woman would need to follow, that would not mean avoiding sugars entirely and not eating carbohydrates, it would mean eating the right amount of carbohydrates, because we still need carbohydrates to function, and the baby needs carbohydrates to grow. So we do still need to consume those, but in the right amounts and in the right proportions with other components of our food, such as fats and proteins and so on. So there's a lot of advice given around that, and making sure that exercise is done. So in line with the recommendations of 30 minutes on most days of the week, and also exercising within a certain amount of time of consuming a carbohydrate meal can also help control blood sugar levels as well. If this isn't enough, then pharmacological therapy might be required. The goal of our treatment is to have good blood sugar level control while also not causing hypoglycemia. So the targets that we're looking for, this is clinician based, so it does depend on the prescriber or the obstetrician and the endocrinologist, etc. But fasting, usually we would look for a blood sugar level target of between 4 and 5.3, and for example 2 hours after meals we would like to see that blood sugar level somewhere between 5.5 and 6.7 millimoles per litre, and again this is more for the second and third trimester. So the pharmacological therapies that we might use in Australia, we still prefer insulin. We've had lots of experience with insulin, and it's what we would still consider to be first line. Metformin may be considered. It is being used more widely, and having said that, other hypoglycemic agents aren't recommended. So usually we would see insulin or metformin, or potentially both in some women. So we'll talk about metformin. So when we're using metformin, metformin can cross the placenta, and this is one of the reasons that it hasn't been used more widely prior to now. But studies don't show that there are any short-term issues during pregnancy, either for the mother or for the baby. And so we are finding that it has been used more often. The usual starting dose for metformin is 500 milligrams per day. And then that's increased gradually depending on the response of the mother, up to 2 grams per day. With metformin, when we think about things like side effects that the woman might experience, metformin can cause a fair bit of stomach upset, such as diarrhea and nausea. So starting at that low dose helps to decrease the incidence of that, and so does increasing the dose gradually. And also we would recommend that the dose is taken with food to help minimize that as well. If we're using metformin, often it isn't sufficient to control a woman's blood sugar levels, and in that case insulin can be added. Often we wouldn't stop the metformin in that case, because we hope that that would decrease how much insulin that the woman might need while she's being treated with insulin. So often they will be co-prescribed. Again, depends on prescriber preference. So insulin is often required for women, and the dose will often start low, but it will need to be adjusted regularly. So because this is a process that's responding to hormones that's being released by the placenta, it can be really difficult to predict what's going to happen, and so the women are regularly monitored and dose adjustments are made. So it's quite highly individualized therapy. And what's recommended is a basal bolus regimen for a lot of women. So that would mean a rapid acting insulin before meals with a longer acting insulin given at night. And these can then be tailored to the woman and when she finds that her blood sugar levels are highest, and so on. So insulin doesn't cross the placenta. So the baby actually makes its own insulin. So what we are really doing with insulin is just managing the blood sugar levels of the mum. Why we might choose one or the other of these options, particularly why we might lean towards using metformin. Some of the reasons for that could be a needle phobia. So if a woman's scared of needles and doesn't want to have injections or to inject herself. If they point blank refuse to use insulin, if they find that they have poor adherence to insulin, or if they find that one of the side effects of insulin can be weight gain. So for some women that would not be ideal, particularly if they're already obese. And if that's occurring, then perhaps we might prefer to use metformin. But we'd probably want to avoid metformin in some patients, such as those with preeclampsia, or those who have had inadequate weight gain, or if the baby's had intrauterine growth restriction. So in summary, hypoglycemia and insulin resistance are a result of the hormones that are released by the placenta, and this is a type of diabetes that is specific to pregnancy. And all women should be screened during pregnancy according to Australian guidelines, so that we can manage any of those risks that we spoke about and poor outcomes that are associated with poorly controlled blood sugar levels. The condition can be managed with lifestyle modification for quite a large proportion of women. So that's actually a good thing that we can let mothers know, that it's not necessarily, it can be very emotional and have a psychological impact when a woman is diagnosed with gestational diabetes. Often these women are relatively young and have had a significant diagnosis in the past, and so this can be quite a stressful and distressing time. And so being able to say this isn't automatically a indication that you'll need to start insulin or injecting yourselves, because often that is quite a significant fear for women, is good to be able to reassure in that way. But if the lifestyle modifications don't work, then medication might be necessary. And the interventions minimise adverse outcomes for the mother and the child, and that's our goal with this. Often there will be a team that's managing these women, that does include an endocrinologist and a diabetes educator, for example. So we do want to make sure that women are well informed about what's happening, and also, for example, if they are using insulin, that they are confident in the use of the insulin, for example, how it should be stored, for example, in the fridge, in the injection site, so where insulin can be injected, and also how to manage hypoglycemia as well. So women need to, if using insulin, they're at higher risk of having hypoglycemia, so they do need to know what the symptoms are of hypoglycemia and what to do if they experience those, and also how to use the equipment that is supplied to monitor the blood sugar levels. So for instance, their blood sugar, their glucose meters, and how to access test strips and so on. There's a lot to this that they need to get their head around, and so we need to make sure that we're supporting women through this process, because it can be quite significant, and yeah, a very difficult thing for them to manage without some assistance from healthcare professionals. So that brings us to the end of the formal presentation. Hopefully we've got some questions that have been asked. So we might move to answering the questions here. If you do have any questions about what I've discussed today, if you'd like to submit them via the Q&A, I'll just have a look and see. So our first question is, you mentioned that there is a high risk of the mother developing type 2 diabetes later. Does aggressive treatment of gestational diabetes during pregnancy reduce the risk of developing type 2 diabetes later in life? Good question, and I haven't seen any evidence to suggest that it does. I haven't really looked into that, but there is nothing to say that if we do keep it well under control, or if we don't keep it well controlled during pregnancy, that that type 2 diabetes is more or less likely to occur. So I'd have to have a look and see if there is any research that does show that it does. I don't think that, I've not seen any evidence that says that you can prevent developing type 2 diabetes, for example, by making sure that the blood sugar levels are particularly aggressive. Treatment sounds quite aggressive, and so we wouldn't want to be too aggressive with what we're doing, because we obviously also want to make sure that we aren't causing hypoglycemia. We want to keep the blood sugar levels within that good range. But I'm not aware of any evidence to say that we can reduce the risk of developing type 2 diabetes with that gestational diabetes management, but making sure that we are encouraging good lifestyle changes after the birth, and things like exercise, good diet, that sort of thing, to help prevent type 2 diabetes from developing. Okay, so we've got another question. That is, if a woman was borderline for needing insulin therapy during pregnancy, would the stage of pregnancy affect the decision to treat or not treat? For example, is it less important to treat a woman later in pregnancy compared to earlier in the pregnancy? What a great question. So later in the pregnancy, it is as important as earlier in the pregnancy. Obviously, earlier in the pregnancy, we want to make sure that we've got proper growth of the baby, so that we're not ending up with having large for gestational age babies and that sort of thing. But what we also want to do later on in the pregnancy is make sure that the blood sugar levels are managed, because, as I said, the baby makes its own insulin. So when the baby is born, if the mother's glucose blood sugar levels rather were high, and the baby was making a lot of insulin to help keep that, because the glucose does cross the placenta, whereas the mother's insulin does not. So the baby is making its own insulin and regulating its own blood sugar levels. Once the baby is born, if the blood sugar levels were poorly controlled, then that baby is at risk of having unstable blood sugar levels and of hypoglycemia. So the stage of pregnancy wouldn't affect the decision to treat or not to treat, because there is still an outcome for the baby. So yeah, we want to make sure that we are managing those blood sugar levels to have a better outcome for bub in the hospital. Otherwise, they may need to have more close monitoring while they're in hospital, and it may even extend their hospital stay as well. Okay, so probably got time for one more question. Is there any support service for mental health in these cases? That's a really good question. So the diabetes education, there's a, I'm not sure if it's just Tasmania based or if it's Australia wide, but there is a program that women can enrol in, which is called the Coach program, which does assist with various aspects of managing this, and it's an ongoing program that once the woman has had diagnosis of gestational diabetes and enrolled in the Coach program, they have contact with a diabetes educator and are supported during after having had their child for that for all the things related to the potential for developing diabetes and the mental health, that sort of thing. Specific mental health services, I'm not 100% sure if there's one specifically for gestational diabetes. However, there are lots of mental health services, for instance, Lifeline and things like that, that can be called if women are finding that they do have you know, some significant distress associated with this, and they don't have someone to talk to. Often the women's obstetrician can refer them to get a mental health plan from their GP as well. So mental health plans are something that can be really useful, and would be a woman in this sort of situation should be able to qualify for a mental health plan, depending on how distressing they do find it, to be able to get some mental health support from a psychologist, for example. So there are services that exist, specific ones for gestational diabetes. However, I'm not 100% sure off the top of my head, but I can look it up and get back to you, because that's a really fascinating question. Do you have any questions?
I think that's good, Nicole. Thank you very much for the presentation. We've run out of time now, but I'd like to thank everyone for your questions, and a big thank you to Nicole for taking time to present this important information. Please provide your feedback through a quick survey before you log out, as this will help guide further HPS webcast events. It should prompt you automatically when you close out of the session, and we look forward to being in touch again for our next event. Stay safe, and we look forward to being in touch soon. Thank you.